So we're going to have a panel discussion until a little before 9:45. Then we will do the ARS questions again. Hopefully we'll have a little more concordance on the answers. And then we will have a 20-minute break. So with that, and again, feel free, you can still enter questions at any time. They come up here. If you want to say something inappropriate, you can anonymize it, but maybe that's what I do. You don't anonymize it. You're right. So a couple of questions. I think this is a lot of questions on TDM and a bunch on the top-down. So at what level of antibody to infliximab or adalimumab do you change to a new drug rather than increase the dose? So does the level of antibody matter?
I would say yes. Again, knowing that there is not a whole boatload of evidence behind this. We just published in DDS that with using the Prometheus assay, the sort of cutoff was 10. So above 10, theoretically, is when you should move on. Below 10, you can at least attempt to overcome it. Now, again, a lot of it's the clinical scenario. Is this their first drug? You know, what else do they have? How bad is their disease? Again, my personal opinion is I optimize whatever drug they're on, and you know, they really have to fail it before I will move on. And again, remember, if you develop antibodies to one drug, for you know, you're either a high clearer or you're non-compliant, you're going to be at risk for developing antibodies to a second drug as well. And again, that data is with Prometheus. I would be very cautious if you're using the LabCorp assay in particular, because the antibody, it's a totally different scale. You know, you can get antibodies of 500 that are meaningless, right? So if you have an infliximab level of 10 and antibodies of 500, please don't stop the drug, okay? You have adequate infliximab. That is probably just an overly sensitive assay. So again, when you send a test, know sort of ahead of time what the results mean and what you're going to do with it.
So overlap question for the two of you. So if you're using combo when you start, how long do you keep the azathioprine going? And then if you do stop it, what are you doing with the biologic at that point? Monotherapy, add something else, triple the dose? What are you doing?
So my recent approach is to look at 6 months of azathioprine along with an anti-TNF agent, and then stop it, and then look at a drug level a few cycles after that. And then if I'm running into lower troughs, I would dose adjust. If I'm running into antibody issues, consider adding methotrexate, oral methotrexate.
Yeah, so I would say I do something similar, also about 6 months, a year, somewhere in that range, right? If you're on infliximab, 6 months, even with adalimumab, you know, I do this with all of them. Before I stop the immunomodulator, if I haven't done it, which I have, I will check a trough concentration. If it's therapeutic and sort of higher, you know, taking into account, particularly with infliximab, if I stop the azathioprine, the drug concentration is going to fall. So if I have someone with infliximab trough concentration of 10, I'll just stop the azathioprine, follow after another couple cycles, and again, I'm going to, in my head, think it's probably going to come down to, say, around 5, which is still therapeutic for me. I will become, you know, again, not a whole lot of data. If their drug concentration of infliximab is 5, I'll actually decrease their interval before stopping the azathioprine, get it up higher, and then stop the azathioprine.
So follow up to that, someone asked, if you know the drug concentration is going to go down when you stop AZA, why check the level? Why not just increase the biologic and move on?
Because I don't know that, you know, some of these patients, if dosed appropriately, or if I start them at, let's say, a higher initial dose because they were sick, if they have an infliximab trough concentration of 15, you know, when I stop the drug, they'll come down to 7.5, which again is sort of okay for me. Again, I think it mostly has to do with before stopping, you want to make sure you have an adequate drug concentration of infliximab. That again is or adalimumab. That again is the more important thing to me. You can't just stop or at least I don't think you can just stop the immunomodulator and just hope you have enough drug on board of the other.
Right, I struggle with this concept a little bit, Adam, because I think, to me, the concept of individualized therapy, but a concept of a therapeutic range may clash at some point in time. So I think what I want to see, perhaps before I apply this universally in my practice with more proactive monitoring and more monitoring before stopping the drug, is the fact that for some patients who are in deep mucosal healing, they may need very little drug. And I think there's that subset of patients who actually may do quite well, even with very low trough levels. And maybe we're looking at detectable versus non-detectable versus, a range.
Yeah, again, to me, when you're looking at drug concentrations, all the negatives have been associated with low drug concentrations, right?
So low as in detectable versus non-detectable, or low, like 3 to 5, or
no? I mean,
that's the issue, right?
Less than 3.5 in one study, which is certainly still detectable. It really, again, to me, it's what's the important thing, right? Gentamicin, it's your high thing. You go too high, you're boxing those kidneys, right? Here, why are we pissing and moaning about 3, 4, 5? Like, get enough drug on board, What happens if the patient goes out of town, they don't listen, they get their drug, 2 weeks later, now they're undetectable, or markedly undetectable. And again, this is not a short-term disease, right? This is a disease of a lifetime. So if you can get your patient and they respond to a drug, to me, I optimize it. And I tell them, like, this is your disease. They know. If they're going on vacation, they're coming in before. That, we talk about the potential downsides to TDM, which is mostly out-of-pocket costs. So it's, to me, the big loss here is low or undetectable, is associated with worse outcomes. And in fact, again, a lot of the studies are showing that ADA of 10, infliximab of 10, like those are really what are associated with mucosal healing, histologic healing, the better outcomes. Again, if I have a patient, and oftentimes before stopping an immunomodulator, I'm going to reassess their disease and make sure they've had either mucosal healing or marked improvement before I make any changes.
So just to confirm, so we're not using the trough level as a surrogate for mucosal healing. You're looking at two variables
totally
separately, right?
Yeah.
Because I think that's the danger of looking at or overlooking at or focusing too much on the level versus looking at two things, mucosal healing and then looking at, drug levels. And again, we can argue whether it's detectable or
like I said,
low or medium.
if I have a patient who's got infliximab drug concentration of 5 and they're mucosally healed, that's okay with me. I will sort of keep them around there. But like I said, if they're 5 and they still have significant endoscopic disease, but they're in clinical remission, I'm going to push them. I'll push them higher. They just may need more
How
drug.
about the opposite situation? Endoscopy shows persistently active disease improved, so they responded. Drug level is 22. What are you doing there?
So I dose de-escalate.
No, they still have endoscopic disease activity.
So endoscopic disease activity with an infliximab concentration of 22, significant. Then you're having how long have they been on it? Did you give them enough time to heal? If the answer is yes, you sort of talk to them about potentially switching mechanism that even though you clinically got better, you still have significant disease. If it's real, deep, linear ulcers and you're worried they're going to lead to a complication, I would talk about switching drugs.
Okay.
That's rare.
Epstein-Barr virus. So are either of you checking EBV status prior to starting AZA? If you are, what are you doing with that information? And the other question is about combination therapy. Is there an age limit? Meaning, as patients get older, we know they're higher risk for infections, malignancies. Is there an age limit? Ghassan, you probably don't have an age limit because you're pediatric, but is there an age limit one would not use combo in? So first question is about Epstein-Barr. What are you doing with that?
So as of recently, actually, I am checking my EBV and CB titers, and it's age dependent, right? So I'm looking at a 12-year-old or a 10-year-old different than I'm looking at a 19 or 20-year-old, and I take care of kids and young adults up to age 21. So my new practice is actually to check the titers. Now, if they're seronegative, and again, the danger is when they're seronegative and they seroconvert, and that's for not all of the lymphoma and the cancer risks, but a lot of them. If they are negative, I would rather not use an immune modulator, the thiopurine, for that patient. I'd rather use methotrexate. And again, I'm not basing this on data. I don't think we have data to support this. This is my opinion and my take on what we know. I'll point this out. In the registry where we pointed out the HLH risk for females, the duration of drug use was in some children less than 6 months. So again, we know that the cancer risk seems to be with a duration of longer than 2 years. But again, that seroconversion seems to carry a very particular risk in individuals who are CMV negative or EBV negative.
Yeah, so I don't see kids in the last probably 2 years. Again, Jean-Fred Colombel was sort of a big proponent of this, again, with not that much data. So any of my patients, 25 or under, I will check an EBV. I just check EBV. If they're seronegative, I don't use azathioprine. Most of your patients, as over 25, as you showed, almost everybody has seroconverted.
So can you elaborate on why in an EBV negative you would not use AZA? I know there's limited data, but what is...
those are the ones you're worried about getting either HLH or post-transplant lymphoma, PTSD. That's the ones you're worried about getting these aggressive lymphomas.
If they get acute EBV.
If they get acute EBV.
Okay.
Don't worry about it so much.
Don't worry about it.
I will.
You do?
I will worry about it.
You do
He's
worry about
peds.
it. He's peds.
To the adults out there.
So one of the questions, if TDM is so great, this is not my question, although it sounds like something I'd say. Why do drug companies that make the biologics themselves not include TDM as part of the drug?
Well, because it's not in their label. So if it's not in their label, they can't touch on it. You can't even ask them about it. I can tell you that, I don't know how it's happened or what it is, but Janssen via Maraca gives away 2 free infliximab drug concentrations a year for your patient. So there is that available. So again, every patient, short of being on Medicare, if you use Maraca, there's a special form, you get 2 free assays per year per patient. And that somehow is funded through Janssen. Don't ask me the backdoor deal. So they do it, but again, you can't ask them about it. If it is not in their label, they cannot talk about it.
So are you still checking 6-TG levels?
No.
Adam?
So for the few patients that I have on azathioprine or 6-MP, I check levels when they're not responding, or they lose response. I'm worried about compliance. They have abnormal liver function tests, or back in the day if I was going to add on allopurinol, right? Those are the situations I'll do it. I'm less proactive with 6-MP. I don't think the data.
So is that, when you're saying that, is that monotherapy or combo therapy? Are you checking AZA metabolites or thiopurine metabolites if you have a patient on combination therapy? If both of you are saying, 6 months and I'm probably going to get rid of this, are you checking it at all? Assuming normal labs, patients tolerating it.
So prospectively, we know that some of the prospective trials did not show benefit when you use monotherapy when you maintain with azathioprine or 6-MP. There's no clear prospectively studied benefit, number one. And number two, to the point that Adam and I reviewed in our slides, that you are probably looking at potentially lower 6-TG therapeutic levels. And the flip side also, when you sort of dig deeper into the hepatotoxicity issue, the high metabolite level can double the risk of hepatotoxicity, but a normal level doesn't take it away. So I also keep in mind that, you know, the over-reliance on metabolite levels is not justified. There's no safety in the standard dose with standard 6TG levels either. So if you have somebody with elevated liver enzymes when you start 6-MP or azathioprine, I'm reducing the dose.
So are either of you using, quote, half-dose azathioprine? Then since Adam showed data that might be sufficient?
I am, and I have to say, again, not evidence-based. And if you want to stick to the evidence in the SONIC trial, it was 2.5 milligrams per kilogram. So I am not, maybe it's to make myself feel better about the brief overlap, but that's my practice.
Are you using half-dose, Adam?
I use so little combination therapy these days. The people I use combo therapy on are my patients that either I don't trust to do TDM as I am requesting, or I fear they're not going to be compliant with the drug. Those are the ones I will use combo therapy on. And to be honest, in those patients, if I'm going to do it, I'm typically using the actual, 2.5 to 3 mg per kg of AZA. Again, because my fear is they're not going to be compliant with their biologic dosing.
Okay.
Or their TDM.
Question about top-down. If you find a patient with mild ileitis on an asymptomatic screening colonoscopy, and the biopsies suggest it's Crohn's, but the patient has no symptoms, is that someone you top down in?
So obviously that's not a patient I typically see because I don't do screening colonoscopies unless my younger patients have had IBD for a long time. So I think you can answer this better than myself.
Adam?
You're doing a screening colonoscopy and you see ileitis.
No, I mean, first of all, if I just see a couple of aphthay, I'm pulling out and I was never there, right? Like, if you nope, it's NSAID, that's it. If you pop in, and I do mostly for practice, if they have what looks like significant ileitis, that's a whole other discussion. I bring them in, I'll talk to them, we'll get an MR, see if they have disease. If they're truly asymptomatic and you're not really getting anything out of them for a story, I'll follow them, I'll repeat it in a year, I'll see where they're going. I mean, there is a subset of patients, even with known Crohn's disease, that have a benign course, right? So we're very good at, if someone clearly has moderate to severe disease, right, we should be appropriate with our use of biologics. We're not very good, and maybe Brian can enlighten us. I don't think we're good at treating mild Crohn's disease, right? I don't use 5-ASAs for, sort of ileal, even true colonic, deep Crohn's disease, but I'll follow patients. I have a number of patients on no drug with clear Crohn's ileal disease that I follow. And, I'll keep an eye on them endoscopically and watch their symptoms. And, we're not great, despite some data, at predicting who's really going to progress. Perianal disease is easy. They'll usually end up on a biologic, but sort of limited disease I find difficult if they're asymptomatic.
So really trying to risk stratify, get a history from them, and making a decision, which is what I usually follow them.
Yeah, it's easy when they've had the disease 10, 15 years and you know their disease course. They've done fine on nothing or misalamine. They have a good disease course. The toughest ones are your sort of newly diagnosed when you say, okay, well, they're young. Well, just about everybody is when they're diagnosed. They have ileal disease, that's a risk factor. They don't have perianal, again, if they have deep, really significant ulcerations, I will talk to them about, sort of biologic therapy and, are those patients better maybe candidates for ustekinumab or vedolizumab, based on the side effect profile? Maybe that's the way we're going to head in the future, is we're going to start with why everybody used to use misalamine and Crohn's is because the medications had, no side effects. Well, they weren't effective, so that sort of throws that out the window. But now we have 2 other drugs, and soon to be more, that are, pretty damn safe and pretty effective. So maybe that's going to be the entree for some of these patients.
Okay. Last TDM question, then we're going to go to the ARS and a break. So which TDM test do you favor? Which would you use? And this may be regional, right, because of insurance reasons and access, but what do you prefer?
I mean, right now, all my data is with Prometheus, and I'm comfortable with it, so that is what I use. And again, because of how I use it, I'm very sort of specific. So I'm currently still using Prometheus. That being said, I'm not shy. I hate the company. I hate how they work. I hate what they do. But I like their assay. So, and I'm comfortable with what the antibodies mean. So again, LabCorp's cheaper, Maraca's cheaper. Maraca's got 2 free. There are other assays out there. Mayo Clinic's got an assay. Again, whatever you do, use it. If there's some confusion, maybe that's when you check a Prometheus, because again, I think at least our data is sort of pretty clear on what you do.
Do I have time for one question for Dr. Cheifetz?
Sure.
Okay.
For you, anything.
Thank you, Scott. One thing that I find challenging with the concept of therapeutic drug monitoring is, taking the data from podium to clinical practice. So the scenario that comes up is you have a patient stable on infliximab infusions, and it's week 6, and they call you. They're on Q8 week infliximab, and then they have symptoms. They have diarrhea. They are seeing some blood. It's week 6. You rule out infections, and they're sitting, in your clinic week 6. The question is, what are you doing that week, that day? Are you checking levels and waiting? Are you starting them on something, or are you dosing infliximab? And do we have data for trough levels week 6 versus week 8?
Right. So the short answer is my patients don't flare because I'm proactively treating them. So I rarely run into this. But if I did, no. So if they call it week 6, they have symptoms, I rule out infection, I find objective evidence of inflammation, I'll check a drug concentration, and I'll empirically dose them. There's no harm, right? So they get 1 dose, it's early. If they get better, boom, fantastic. You get a drug concentration back 5 days later. It's likely going to come back low, whether they have antibodies. You can sort of work with it then. I'm not going to withhold drug, just to wait for a drug concentration. Again, where are we heading in the future? The point of care testing, I think. So you'll have it right away. And again, I think eventually where we're really heading is ways to model how much drug a patient needs to attain whatever drug concentration they're getting to, and using that early on.